Good afternoon, and welcome to the last plenary of the ISAM 2025 in Hamburg. So over here, it's gives me an honor to present Professor Anju Dewan. She's a professor and chief of the National Drug Dependency Treatment Center, All India Institute of Medical Sciences, New Delhi. She will be talking about the adolescent substance use management across different settings in India. So the floor is yours, Doctor.
If we talk about adolescent substance use in India, looking at the figures in terms of the prevalence, this shows data from the National Household Survey, which was conducted in 2019. And the two columns compare the current use in last 1 year in adolescents as compared to adults. And you can see that the figures for opioids are very similar between adolescents and adults. Inhalant use is in fact higher amongst adolescents than adult population, and cannabis is also almost 1%. In terms of the numbers who are using substances is quite large, amounting to several hundred thousands. We know that adolescent substance use is overall associated with lower recognition of the problems. Many of them may not be dependent, but they would be using substances in a binge pattern, substances such as alcohol. Comorbid psychiatric problems are more common in this age group, and their focus is more related to their immediate concerns rather than what would be the long-term consequences of their substance use in terms of developing health damage, etc. And peers at this age are much more important than they are when people grow older. But often adolescents do not seek help in treatment settings. In our treatment setting, for example, most of our adult patients, when we talk to them, they report that they started their substance use when they were in their teens. But amongst the total people who are seeking treatment, less than 5% are adolescents. So there is a gap between their onset of substance use and coming forward for help. And the reasons could be very many. One is that there are very limited number of treatment facilities for adolescents, and those that are there where adults are coming forward for treatment are not perceived to be very adolescent friendly. In the early stages of their substance use, people may not perceive that they have developed so much problems to the substance use. Their family members or relatives may still be unaware. Thus, that motivation which family may exert pressure to seek treatment may be missing. They may be concerned that if the family members come to know, concerns about confidentiality, lack of motivation, all these could be factors that may play a role. So when we started our adolescent substance use treatment clinic in India, which was the first in the country in 2003, there were very few adolescents who were coming forward for treatment. And we knew that there is a large number in the community who are there, based on our interactions which we had been having over the years with our adult patients, and all of them started their tobacco in their 14 and mid-teens and so on and so forth. So it was important to look at other settings where we could seek them out and identify and provide interventions early on in their course of substance use, rather than once the chronicity sets in. And what were these settings? These could be in the community, children who are out of school or children who are living on streets. It would be schools. It would be general medical settings, besides our own specialized drug treatment setting. And in the other settings, the screening and brief intervention became more important. So in my presentation, I'll be initially talking about the settings other than the specialized drug treatment setting first, and then talking about our experiences with managing adolescents in the specialized drug treatment setting. So when we look at early identification and intervention, We know that it is very important because substance use disorders may range from problematic use then going on to dependence. And in case of young people, it exposes them to several other risky behaviors, accidents, injuries, sexual risky behaviors, etc., and may lead to development of dependence later on. So, brief intervention, we are all aware what it means. It targets the harmful, hazardous users, not just the dependent users. And it's a short intervention, usually with 1 to 4 sessions, focusing on reducing harm and need not be abstinence oriented. The goals could be engaging the adolescents in treatment, it could be reducing the substance use, it could be also retention in treatment. Since it's based on principles of motivational interviewing, which is a non-confrontational approach, it is all the more appealing to young people, where it can engage them very well in treatment. And it helps to assess the readiness to change and plan a corresponding strategy based on the stage of change. If we look at the available literature on effectiveness of brief intervention, there is a whole lot of literature, but if we look at that specific to adolescents, the review of brief intervention in adolescents, this review was done in 2003, which found across 11 studies, there was a small effect on alcohol consumption and tobacco consumption. On where multiple substances were being used, there were only 2 such studies. The effect was substantial, but the sample was small. A more recent meta-analysis of brief interventions for substance use in adolescents, 22 such RCTs, have found that it reduces the heavy alcohol use days, and problems in adolescents, but did not find to have an impact on the cannabis use days. Then there is a review which looks at BI in cannabis users, and 8 such studies which looked at provision of BI in primary care settings. And most studies had a single session, and they found trends of decreased cannabis consequences, various kinds of consequences, but there was no significant reduction of cannabis use in long term. So overall, studies are not very conclusive and they are still very limited, but brief intervention still remains an important modality because in adults it has seen to be working, and that's what we were trying to do. If we look at general medical settings, it becomes very important because adolescents may come there for other health issues, and it could be a place where they could be screened and substance use could be identified and intervention provided. In India, we have the National Adolescent Health Program called the Rashtriya Kishore Swasthya Karyakram, which was launched in 2014. And it was heartening to see that one of the objectives is prevention of substance misuse, the way it is quoted in this program. And you can see that several of the other objectives are also somewhat have an overlap with substance use, whether we talk of preventing injuries and violence, enhancing mental health, and even improving sexual and reproductive health to some extent. These clinics which are run under this program are called adolescent-friendly health clinics. And they are located in every state of India, where adolescents may walk in for minor kind of issues, and also sometimes to seek other kinds of help, such as getting for adolescent girls, there are iron tablets available, sanitary napkins available, those kind of facilities to increase their seeking help. The program in Delhi is called the Delhi Initiative for Safeguarding Health of Adolescents, and there are 25 such clinics in Delhi, the acronym being DISHA, which means direction. These clinics include doctors, nurses, and counselors, and the capacity building of service providers for effective and successful implementation of this program has been carried on in a large scale by the Adolescent Health Program. But substance use training just constitutes one session in this. And we have been advocating to have at least a few days of continuous training to enhance, further build the capacity in managing for substance use. This is a study which showed that when pediatricians, many felt unprepared to diagnose alcohol use and other drug use, But if they have somebody who's assisting them in screening and reviewing the results, then with a potential screening facilitator, they are more likely to provide interventions for substance use. Through a study funded by the Adolescent Health Division, Government of Delhi, we trained the nursing personnel in these adolescent-friendly health clinics in administration of the youth version of Assist Y, and with referral to doctors for provision of intervention. And the plan was to further conduct training of the nursing staff in providing BI. However, there were some challenges encountered. Although many of, in this study we were screening for other mental health issues as well. The screening for mental health issues was better, but there was a lower rate of identification of substance use. And that was partly, when we looked at the qualitative data, it was because of difficulty in terms of time available to staff for screening, lack of privacy, concerns about confidentiality, etc. But none of these barriers are the kind that cannot be overcome. If it is prioritized as an important area, these adolescent-friendly health clinics, which are there across the country, can serve as very important settings for screening of adolescent substance users. Another setting which is very important is the schools, where a large number of adolescents are seen. They're spending a lot of time in the schools. The school personnel can be trained for screening, not only for, of course, for prevention, but also for early identification and intervention. This is data from a 10-city student survey carried out in 2019 in India, where we looked at the prevalence of substance use in students studying in class grade 8th, 9th, and 11th. And we found that any substance use in last year was present in about 10% of the adolescents, which is quite substantial. And there was also a high rate of continuation of substance use in those who had ever used, indicating, although these figures are still much lower than what we see in the West, but there are concerns that these are probably on the rise in India. So it becomes important to have our schools be prepared for identification and interventions. Meta-analysis of school-based alcohol interventions is available, which was carried out in 2015, which looked at 17 studies and found that it reduced alcohol consumption. The meta-analysis also found that this was more effective when done individually, but group-based screening and brief interventions were not associated with reduction in alcohol use, which suggests that it has to be one-on-one. However, a Cochrane review, which was probably more selective in picking up the studies, and it was not limited to just alcohol but other drugs as well, looked at 6 studies, and the conclusions were that it is not possible to make definitive statements about effectiveness, and further studies are required, particularly in low and middle income countries, because most of this data came from high income countries. In our experience, we found that the teachers can be trained to identify the early warning signs of substance use, and a large-scale orientation of teachers in Delhi was carried out based on a court directive where there were concerns that substance use was probably increasing amongst adolescents, with referral to school counselors where the counselors could be trained, and during even prior to COVID, and also online trainings during COVID period were conducted for the school counselors. However, one major concern here is the shortage of school counselors, because many of the schools are not equipped, especially the government funded ones, are not adequately equipped with school counselors. And once the school counselors are able to, once the teachers refer to the school counselors who provide brief intervention, if withdrawal management has to be done, then how would that be done? That referral chain needs to be established. India has a strong school health scheme where doctors do routine screening of school-going children for other health issues, such as an eye and a dental checkup, etc. And they could very well be trained to provide medication just for the withdrawal management. because these adolescents who may need this kind of medication assistance would anyway be a very small fraction. The study that I just talked about, the school-based survey, also showed that most of the users were using either occasionally or intermittently, and a very small proportion were actually regular users. Also, more severe cases could be who need more intensive psychosocial intervention would need referral to specialized treatment settings. As part of this work that most of it was done during the COVID period, we came up with these standard operating procedures for schools which define the role of each person in the school, what would be the principal's role if a child is identified, and even for prevention perspective, what would be the role of teachers, counselors, etc. And we found this good screening instrument which could be used in school settings which are small and doable for teachers who anyway have multiple responsibilities. A manual for counselors, school counselors, was developed based on the principles of brief intervention, which not only gave the knowledge but also provided examples and case vignettes, etc., about how to actually build their skills for providing BI in the school settings. But there's a lot of work which still needs to be done in this area. Now, coming to the third kind of setting that I wanted to talk about, which is out of school children, and one extreme example becomes the street kids. A lot of studies have been carried out over the years, and they have shown that substance use in street children in India across various studies has ranged from 40 to 80%. There were concerns about the sampling of these studies, and we conducted a study that was representative of the sample of street children in Delhi using respondent-driven sampling. And based on this, we found that about 33% of them had used some substance in last 1 year, and you can see the prevalence of various substances. Cannabis, about 8%, inhalants, 11%. The use of opioids was still relatively lower. Another nationwide study which looked at children who are using substances found that if we looked at the mean age of initiation of various substances, the out-of-school children and those who were living on the streets had a younger age of initiation. The more vulnerable the child, the earlier he was likely to start substances. And that's why in children living on the streets, one may see substance use at a very young age. With the help of a WHO-funded Binium project, we looked at developing a group intervention for substance using street children. Group intervention because children, when they're living on the streets, like to live in communities. There is no privacy there to conduct individual sessions. The community there is a family for them, and it makes sense to provide interventions also in groups. And this 6-session intervention was developed after comparing children who were users and those who were non-users and looking at factors that were different between them. And this intervention was largely based on activities and games and focused on motivation, relapse prevention, and other life skills such as taking care of their health and managing their money. The intervention was delivered by the non-governmental organizations who had been having a street presence for many years. Our job was to provide training to these NGOs, because to be able to interact with street children, you can't just walk into the street and start working with them. There had to be an ongoing relationship which these NGOs had been having for a long time, and they had the trust of these children. The pre-post assessment results were heartening and showed improvement in motivation and confidence in ability to refuse drugs. Also improvement in the drug use per se as per subjective report, and especially contact with the non-governmental organization further improved. So the study helped to document that NGOs who are working with street children can identify substance use. Interventions can be provided in the same setting to make it more accessible. And another work which I had just shown, the Delhi-based study, also showed that about 25% of children who were living on the streets were actually living with their families. So it becomes very important to involve the family members as well in provision of intervention. Family members may also be having a high substance use, as was seen from that work, and engaging them in treatment, providing them treatment for their substance use may also affect the outcome in these children. India has a child helpline, which is a nationwide service, and this is the number which one can call, 1098. The NGO responds to the calls and makes community visits or home visits and carries out intervention in the community. If the child needs to be placed in a children's home, then the case is presented to a child welfare committee and the child is admitted if both the child and the parents are willing for that. There are about 100 childline NGOs which are working under the mother NGO, and they were trained in identification of substance use and conducting this 6-session psychosocial intervention that I just talked about. Now, more recently, the National Action Plan for Drug Demand Reduction by the Ministry of Social Justice and Empowerment has set up community-based peer-led interventions across the country run by the non-governmental organizations, which focus on peer education, life skills training, identification and linkage. The staff of these CPLIs also need to be trained in brief intervention, and these could be a very useful resource for providing the intervention there in the community and then linking them with more intensive treatment if required. Now, the second part of my presentation, I would like to talk about experiences from working in the tertiary specialized drug treatment setting in India, which is the national center in the country. Based on a 10-year chart review, which was done, retrospective data, the profile of adolescents can be seen. The mean age of adolescents who come to us for treatment is 16 years, but we have seen as young as 8-year-olds. And almost half of the adolescents who are seeking help are students, and some of the others are working in petty jobs in the informal sector. Most of them come accompanied by parents or other family members. We don't see so much of referral from schools to the clinic in our setting. Mostly it's the family who's bringing them in. Even if we try to engage the school, there are concerns that how would the school respond? Would it lead to any adverse academic outcomes for the child? Those kind of concerns are there. In terms of substance use in the treatment setting that I work in, these are the prevalence figures of various substances which are seen in the setting. A large percentage of them are using tobacco. Out of the other drugs, it's mostly volatile solvents, cannabis, alcohol, heroin, and some using other opioids and benzodiazepines. Although the primary drug for which they are seeking help is usually opioids, inhalants, and cannabis. If we look at various substances, then the proportion of users of a substance who are dependent, as expected, most of the people who are using heroin are dependent on heroin, and a large proportion of those using other pharmaceutical opioids are also dependent on them. Pharmaceutical opioids that we see were used to be mostly spasmoproxivon, and now it's more of tramadol, some use of buprenorphine amongst adolescents. These are the two common substances. Solvents, about 2/3 reporting dependence, and cannabis, about half of them. Based on this data of retrospective chart review, we compared the opioid users and the non-users. The opioid users the non-user opioid group was largely using inhalants. The opioid users were older, more of them were school dropouts, and many of them came unaccompanied by family members, coming alone into treatment. They were also using other substances like benzodiazepines, and injecting drug use amongst the opioid users was seen in 23%. Overall, the group reported the entire group of adolescent substance users reported financial difficulties, legal problems, problems if they were working, but this was more in the opioid users. Coming to motivation and retention. Motivation may not always be good. Sometimes the family member may have brought the adolescent forcibly into treatment. Dropouts are high, 50% dropout after the first visit, so window of intervention is very small, and one needs to provide intervention at the first sort of contact. Family may have come to know about the substance use very recently, so their distress may be quite intense. The engagement of family and patient in the treatment process both are important, because then it may be challenging because their goals of coming forward for treatment may be very different, and the family may be looking for immediate solutions. Sometimes what was mentioned in the previous presentation from Iran, they may be looking for sort of inpatient setting, long stay, etc. So they have to be educated about the nature of treatment, and they have to be educated about the treatment process and still be engaged in the treatment. The initial assessment itself is focused on understanding the factors that may have contributed to the vulnerability, assessing the strengths or resources and challenges, and developing a treatment plan. And if there are some health issues, then a referral for those as well. Now, if we look at management of adolescent substance use, most of the literature that is available talks about psychosocial intervention being the mainstay of management. Overall literature on pharmacological intervention is very, very limited. But if we talk of opioid-dependent patients, we know that pharmacological intervention is a very important part of the treatment. This was a good update on adolescent substance use disorder evidence-based strategies. And I wanted to highlight that all the well-established standalone interventions are psychosocial interventions, family-based CBT. And the pharmacotherapy is listed as a possible adjunctive intervention, which is actually not so true for opioid-dependent adolescents, where it still becomes the mainstay of treatment. Most outpatient and inpatient programs use an eclectic approach, integrating multiple therapeutic models. And family-based interventions are an important part of adolescent substance use treatment. Various kinds of family-based therapies are available, but these are sort of the common key components where parental monitoring is important, helping to improve the relationships, helping the adolescent to manage his emotions and stress. These are the, and identifying parents who can be the agents of change, a parent or family member. In our treatment setting, these are the issues we focus in our sessions with the family members. We educate them about the drug use, the process of treatment and recovery, and engage them in the treatment process. We identify one or more parents who will be able to come regularly for follow-up, because there may be concerns about losing a day's work or younger sibs being at home and the parents not being able to come frequently. The focus is again on improving relationships and how the parents can support the adolescent to handle high-risk situations, which may include monitoring, which is willingly done with the adolescent's consent. Also facilitating other recreational, vocational skill development, etc. And for this, although there are government schemes available, usually the informal sector is what the family uses. Family may have their own resources, he may accompany the father to work, etc. Or just to learn a skill. Working wouldn't be permitted, but then further helping the adolescent to enhance their other skills. Now, coming to pharmacological management, we know that the efficacy of psychosocial treatments is at best modest. The pharmacotherapy needs to be explored as a potential complement, but there is limited data. Most of the RCTs exclude adolescents when they are conducting the studies, and that's why it is difficult to extrapolate the results to adolescents. There are no FDA-approved pharmacotherapies for adolescent substance use disorders except buprenorphine, which is permitted at age 18 onwards. This is just to show a table to show the limited amount of literature on pharmacotherapy that is available, whether we talk about tobacco or cannabis or alcohol. And now coming to management of opioid withdrawals, this is a study which compared clonidine and buprenorphine and found both to be effective for management of opioid withdrawal, but buprenorphine did better as expected. Now, when we talk about adolescents, very often the question we are asked is, he's a young person, are you going to put him on long-term maintenance? Would we not just manage the withdrawals and then taper and stop medication? Yes, for most people that is what is desirable, but there is a category of adolescents who may be on the severe end of the spectrum, who may be injecting drug users, may be transitioning to becoming homeless, etc. And agonist maintenance becomes an important option in such cases. And literature has also supported that if we look at short-term withdrawal management versus relatively long-term maintenance, this is actually only 2 or 3 months duration of maintenance. These studies have shown that it reduced the dropout and increased the and also reduced the opioid positive urine. So there is a merit in talking about maybe a longer withdrawal or at least a shorter maintenance at least in cases of adolescents, in cases of many adolescents. If we look at a retrospective chart review which looked at 103 adolescents, this literature study showed that compliance was high with buprenorphine naloxone and had 45% retention at 2 months, but reduced at 1 year. This was a very interesting article which talks about the pros and cons of providing maintenance treatment for opioid use disorder in adolescents, and it's a narrative review. It looked at that the studies again being limited, but retrospective studies have shown that methadone appears to be effective in promoting retention. For buprenorphine, there were 3 RCTs and 3 retrospective cohort studies which showed that the risk, that it improved opioid abstinence and treatment retention. So this review made a case that the overdose risk being much lower for buprenorphine than methadone, but one of the cohort studies suggested better retention with methadone. So the argument at the end of the paper was that overall the risks of untreated opioid use disorder far outweigh the risks of medications, and at least in some cases it should be considered. This is an RCT on 6 months naltrexone plus psychosocial versus psychosocial alone, and it showed that control subjects use more opioids than the naltrexone subjects. Another study, which is a case series, also showed that people did well on extended release naltrexone. In another study, retention with naltrexone as compared to buprenorphine was found to be good. We conducted a study at NDDTC at our center, which is in the process of being sent for publication. In a retrospective chart review of adolescent opioid-dependent patients, we looked at which long-term treatment were they put on. Majority were initiated on naltrexone, about 40%. Naltrexone group had less number. When we compared those who were put on buprenorphine and naltrexone, we expected there will be a lot of differences between these two groups. But there was not so much difference in terms of the socio-demographic and other drug use profile, but the naltrexone group had less number of admissions at baseline. So retention and abstinence rates amongst those retained on naltrexone and buprenorphine at 2 months and 12 months showed differences, and surprisingly the naltrexone group did better than the buprenorphine group. But there was a crossover of almost 40% from one group to the other during the course of treatment. So anyway, in India, we use antagonist treatment as a first-line treatment even for our adult patients, and more so for adolescents. But if there is a failure of treatment or their severity is so much, then we plan agonist maintenance. So this is the data just to show that the crossover happened between these two groups. People, some from naltrexone moved to buprenorphine or tramadol, and and so on. And the differences in terms of retention and abstinence rates at 2 months and at 12 months. I'm not sure my... Now, coming to the relationship between substance use disorder and psychiatric disorders, I don't think a discussion about adolescent substance use management is complete without discussing this. We know that individuals who have externalizing disorders, their risk of substance use increases substantially, and the prevalence of various disorders in adolescents who are having substance use disorder varies in terms of conduct disorder, ADHD, depressive disorder, etc. Now, when to treat? The symptoms of substance use may be indistinguishable from ADHD symptoms, and it is usually desirable to first treat the substance use disorder until unless there is a clear, well-documented history of ADHD preceding the onset of substance use disorder, when both could be treated concurrently. But many times we do see in our setting as well, adolescents who are well maintained, for instance, an opioid dependent adolescent well maintained on naltrexone or agonist maintenance, still not being able to function that well, showing irritability, behavioral issues, etc. And once being treated for ADHD, which gets diagnosed, then the many other things also settle down, and those behavioral issues settle down, and the functioning improves. So overall, to summarize, early identification and intervention is important in community schools, general healthcare setting, and many other settings such as children homes. Capacity building of personnel in all these settings becomes very important so that they can there and then do the screening and provide brief intervention. Specialized drugs treatment services also need to be enhanced. Many more need to be created for adolescents, largely outpatient, but some also inpatient as and when indicated. In our setting, the common drugs we are seeing are opioid, cannabis, and inhalants for which treatment is being sought. Treatment seeking is low, and treatment engagement of both the patient and the adolescent and the family is important. Most of the literature is on psychosocial intervention, where family therapy and CBT have been found to be effective. And pharmacotherapy also has an important role to play, especially in cases of opioid dependence. And much more research needs to be carried out in terms of pharmacotherapy, and more RCTs should take place in adolescents. But since the number seeking treatment are few, even to carry out an RCT, it would be required to have a multi-centered study. That's one of the challenges we have also faced, because to get an adequate effect size, you may not get enough sample from one setting. Thank you very much.
Hi, thank you so much for your talk. Could you comment on the increased use of inhalants in adolescents in India? And if you're seeing, like, what kind of trends you're seeing with that for inhalants?
Yeah. So inhalant substance use, earlier on we used to mainly see it in out-of-school children who were, children, very vulnerable children who were living on the streets. But then for the last decade or so, we started also getting reports of use in school settings. And the prevalence in one study that we did in 2 schools in Delhi was about 8% had used at some point of time in last 1 year. In case of adolescent inhalant users, the withdrawal symptoms are not so prominent, but the craving is very intense, and the challenges are in handling that craving. The major challenges in terms of lack of pharmacotherapy. So usually we give low doses of benzodiazepines to manage the initial withdrawals. And again, studies are not very many, mostly case series and case reports. And then the psychosocial interventions also, literature suggests that they're very similar kind of interventions as you do for other drugs, family therapy, CBT, etc. should be done. One concern about inhalants is that they are known to have a lot of health damage. and there is a risk of sudden death which is associated with inhalant use. So, Dr. Roshan is here, I think. He carried out a study where we found out that in the adolescent inhalant users who are coming to our treatment setting, we found some signs of peripheral neuropathy, some nutritional deficiencies. On psychological testing, there were cognitive changes which were there, which are also reported in literature. But fortunately, we did not see other kind of health damage such as liver, kidney, etc., which is reported in literature. But the sample was very small for that study. It was about 23 adolescent inhalant users. There are reports of mortality which our patients sometimes tell that, you know, one of their friend died because of sudden death following use of inhalants. I think the risk perception needs to be enhanced. It doesn't seem to be a drug which is on the rise, but it is there in the community.
Well, thanks a lot, Prof, for that very nice presentation.
Thank you very much.
Yeah.
Thank you. Thank you very much.